Welcome everyone to our next interview for Sharing Progress in Cancer Care. I'm very honored today to be in conversation with an amazing physician, an incredible educator, and one of my own personal teachers for a few years now, Dr. Howard Schubiner. So I would love to, Howard, welcome. I am so honored that you're here with us today.
You were too kind, but thank you so much. I've loved having a connection to you and the work that you're doing. So thank you.
Thank you so much. Howard, we have already had you as one of our speakers at an incredible convention in Rome around pain in oncology. And it was probably one of the best received lectures in that conference. So I really wanted to talk to you and really allow for your wisdom and your expertise to be available to many, many more people who weren't attending live in Rome and who will hopefully be very drawn to your work going forwards, because what you do is applicable across all specialties in medicine and certainly oncology. So before we really dive into one of my favorite topics, I would love to read your bio to our viewers and listeners. So
Okay.
Dr. Howard Schubiner is an internist and a pediatrician, a full professor at Michigan State University College of Human Medicine. He's on the board of directors of ATNS, Association for the Treatment of Neuroplastic Syndromes, and he sees patients at Cormandi Health. So we will link all of this in the notes in case anyone wants to get in touch with Dr. Howard Schubiner. And also, he has authored hundreds of publications in scientific journals and books and lectures globally and internationally. He has written incredible books, one of which I have right here with me. The fourth edition is now out. Unlearn Your Pain, a 28-day process to reprogram your brain. Why manage your pain when you could cure it? And then other books are Unlearn Your Anxiety and Depression and Hidden from View, a clinician's guide to psychophysiological disorders. And Howard, I realize you have another book in the works. We're all waiting with a bated breath.
Well, super excited about it, I must say. Yeah, because it's for a bigger publishing company, so hopefully it'll get a little bit wider distribution.
I'm sure that it will. I went through a training course with you, and it was probably one of the most meaningful endeavors I have undertaken since medical school. And there is a quote that we had in our course that says, "What happens in the mind of man is always reflected in the disease of his body." René Dubois.
Yeah.
And also, there is a definition of pain that I would love to kick off with by the International Association for the Study of Pain that says, "Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Pain that lasts for longer than 3 to 6 months, past the normal expected time for healing, is defined as chronic pain." We also learned in our course with you that over 1.5 billion people in the world suffer from chronic pain globally, and this accounts for a cost estimate of around $1 billion annually.
Yeah. Yeah, it's amazing. I had not worked in the field of pain for 20 years of my earlier career.
Mhm.
I had been working in the field. Most doctors really are not interested, frankly, in seeing people with pain because they're a pain. It's hard.
Mhm.
There's a reputation that people don't get better.
Mhm.
And what I've just learned so much in the last 22 years, but one of the things I've learned is that there's diseases that kill us, and oncologists are very familiar with diseases that cause mortality, not to mention, on top of cancer, obviously, heart disease, stroke, dementia, Parkinson's, ALS, chronic lung disease, et cetera. But the diseases that don't kill us, the diseases that cause morbidity, are by far the most common sources of suffering worldwide. And we're talking about chronic back pain, chronic widespread pain, chronic headache pain and migraine pain, chronic facial pain, chronic abdominal pain, irritable bowel syndrome, chronic pelvic pain. And all these syndromes constitute tremendous amount of suffering. And modern medicine has made tremendous strides in cancer and in heart disease. Dementia is even slowing down a bit, but these other diseases are actually rising in prevalence in the population. They're getting worse, and our treatments for them are kind of subpar.
They really and truly are. And from a point of view of an oncologist, thankfully, as you've mentioned, we've made tremendous strides in novel cancer treatments that are working much better than some earlier ones have worked.
Yeah.
And now that our patients are thankfully living longer, at one point in their follow-up, cancer sort of becomes this moot point because they're just fine. And then the consultation becomes around, well, this pain that I've been having, or this side effect from treatment that should have
Yeah.
disappeared years or months ago is still lingering on. What on earth is happening? And we
Right.
really are not equipped with how to deal with this. Sadly, often patients get told even before they come to see us in clinic, oh, it's just in your head.
Yeah. Yeah. And chronic fatigue too.
Yes.
People with chronic fatigue, and then obviously anxiety and depression on top of it. And the treatments, a lot of obviously cancer treatments are so much better with fewer side effects, but still, patients have neuropathic pain from a fair amount of chemotherapies have neuropathies associated
Mhm.
with. And now it can be really hard to say, well, I had this numbness and tingling in my feet or this electrical pain down my legs. Well, we know that was from the chemotherapy, but like you say, months later or years later, is it still there? Is a neurologic exam abnormal or not? Is the fatigue that came with having cancer, why is that persisting when the indices are normal? There's no evidence of ongoing disease or metastatic disease, right? And
Mhm.
it's really confusing and I don't know what the word is, like bewildering, befuddling. It's frustrating for patients and for doctors to not have answers to that. And oncologists are so smart; they're used to having all the answers, right? I mean, what they have to keep up with in terms of new pathways and
Mhm.
genetic changes and new medications is astounding. Um, but what do they do when the patient says, well, my back is still hurting, or my stomach's still hurting, or my headaches, I'm just so tired that I can't get out of bed some days? What do they do then?
Exactly. Oftentimes we forget how prevalent this is in our clinics. And I feel like we had a reminder after COVID with the entire concept of long COVID, which to some extent, at the very least, to some extent, falls under the category that we're discussing today. And I wonder, now that we've sort of listed out these conditions, you've mentioned IBS, you've mentioned chronic pelvic pain, then let's see, small fiber neuropathy, such as peripheral neuropathy, TMJ, for example, one of those syndromes we know, cystitis, tension headaches, migraine headaches, chronic fatigue, all of that. What do we do? Where do we start?
Well, we have to start at the basics. We're doctors. And what is the cause? What's the etiology? But the question is, how do we look? And when I started this work, there's a lot of myths that I'm writing this new book and I'm really diving into this. And, one of the things about pain is that we were taught as physicians that pain means structural damage in the body. If you have pain, there must be structural damage in the body. So we have to look for it. But what if you can't find it? Then what? So you're stuck. Well, it turns out that most, and this is shocking and revolutionary. I had no idea that I would ever be saying this in my career, But the vast majority of people with chronic pain don't actually have structural damage in the body to account for that pain after having, very good and full and detailed medical evaluations. Well, if that's the case, we can't find the structural damage to cause it. How could it be? As you say, so then people get told the pain's all in their head, they're faking, it's just stress, there's nothing wrong with them. And what I had to learn, and most doctors haven't been taught, is how the brain works. That the brain works by predictive processing, meaning that our brains literally create what we experience, which on the surface sounds like a new age, woo-woo concept or something. Oh, we create our reality, right? But it turns out we don't see with our eyes. Our visual cortex generates what we see. You can see when you're dreaming, right? You don't need your eyes to see. And vision is often incorrect or inaccurate because we're trying to take in all this information. People will see different things. Different people will see different things. People who see a crime being committed will pick out the wrong person in a lineup on a routine basis. What we hear is dependent on what our brain hears. And it turns out that when you touch a hot stove, it's not your finger causing pain. I was like, what? How can that be? Pain is a decision made by the brain. And we know that because you can have an injury, and many people have experienced having an injury without pain. And you can have pain without an injury. And when you put those two things together, and then you learn that the brain can learn pain as a neural circuit, remember it, and then keep producing it over time because it has learned that pain. And that's how we can begin to understand how people can have cancer, have disease, have symptoms. The symptoms get learned, the cancer gets treated, but the symptoms persist. And that can be because of learned neural circuits. That is astounding. Okay?
That is game changing. It's that concept of what fires together, wires together, and at the beginning of a certain process, some neurons got wired and just stayed there, maintained their neural circuit that's just fully operational and just keeps firing time and time over and reproducing the exact same experience.
Exactly. And that's what the brain does. It predicts what it should do. And that's it's a survival skill that our brains all have to predict when should we be worried, when are we safe, when are we in danger. And the more pain somebody has, the more the brain is predicting pain, and then it's creating pain, and then you're getting more pain, and then it's a cycle. And most people with chronic pain, even most people with back pain, and we published a study last year where we evaluated 222 people with chronic neck and back pain in a physiatry clinic. 98% of them had abnormal MRIs of their back, which is not surprising because that's the data that has been gathered on people who are asymptomatic. Asymptomatic people, if you do MRIs of their back and neck, the vast majority of them as you age have abnormalities, degenerative disc disease, spinal stenosis, spondylolisthesis, bulging disc, without pain. And so what we did, we evaluated these 222 people using a model that doesn't overinterpret an MRI, but looks at the pain characteristics to see if the pain characteristics really fit into a structural disorder. Structural disorders are pain is consistent, they're always there, they're in the same place, etc. They occur with certain positions or movements, like a fracture would. Or is this pain neuroplastic in nature? And neuroplastic pain tends to shift, move around, it comes and goes, it is related to stress, it can be related to the weather. There's a whole variety of criteria. It's in a wide area that doesn't make physiologic sense. And when we did that, 88% of the people were determined to have non-structural back pain. I mean, come on, if you go to a regular PM&R doctor who is just looking at the MRI and saying, well, you've got degenerative disc disease, so therefore that's a structural problem.
It tells me a couple of things. There's so much that I would love to dovetail off of. One of the things I heard you say, and I'm gonna enter another quote that we've learned in the course, which is most pain is not a pain problem, but it's a fear problem. And this is where this predictive processing comes into play. There's a learned sensation of pain that got wired somewhere in our nervous system. And because our bodies, our brains are scanning for danger, just evolution in an evolutionary context and sense, and are predicting when it may happen, we're triggering that pain out of fear rather than out of evidence.
Yeah,
And
exactly.
then as doctors, certainly we are going to do the sensible medical tests in
Yeah.
order to investigate, is there a structural issue? It feels to me that since we're not educated in a way to understand our brains and then work with them, we stop too soon. We just
Yeah.
dismiss things too soon. So, what does a doctor do to rule out or rule in structural pain and then rule out or rule in the neurocircuitry functional
Yeah.
component? How do we do that?
Exactly. So all doctors know how to rule out a structural problem. All doctors know how to look for a structural problem. And the scans are available, the tests are readily available, certainly in the US, maybe a little bit less so in other countries, but nevertheless, um, that's usually fairly simple to do. An MRI of the back doesn't show you what the cause of the pain is unless it has a tumor, a fracture, an infection, an abscess, and vasculitis, an autoimmune disorder, etc. So, and the same is true when you have abdominal pain, pelvic pain, head pain. All neurologists know that 95 to 98% of chronic head pain is non-structural, primary pain. All neurologists know that. It's not hard to rule out tooth and dental and ear and vasculitis and brain tumors, etc. It's not hard to do that. Ruling in a neuroplastic problem is the step that we are trying to help people learn. And it's fairly simple. These are all clinical characteristics. They're published in that paper. And they're published in our books, of course, but it's also published in the paper that I alluded to a minute ago. It was published in Journal of Pain on diagnosing back pain. And so it's I've been doing this for over 22, 23 years now. And it's amazingly simple if you understand just to open your mind to look for neuroplastic pain. And then you begin to say, well, does the pain ever shift or move? Well, sometimes it's in my upper neck, and sometimes it's in my lower back. Why is that? Sometimes it's on the right side, another time it moves to the left side. It's been spreading over time. It started without a reason, or it started with an injury, but the injury healed, or it's in a widespread area. It's triggered by stress. It's triggered by the weather. It's triggered by heat or cold. It goes away when I get an acupuncture treatment or a massage, and then it comes back. When you put all those together, it's usually really simple, amazingly simple. And we can send you lists of these criteria that I call the fit criteria.
Mhm.
Is the pain functional? In other words, not pathologic. Is it inconsistent,
Mhm.
moving around? Is it triggered by innocuous stimuli? So when you put that together, then you have the opportunity to really help people, because we'll talk about treatments in a minute, but we have developed treatments that are extraordinarily effective for not only managing or coping with chronic pain and other symptoms like chronic fatigue, but actually reversing them.
Yeah.
But the key point, as you mentioned earlier, is how can you explain that to someone, right?
Yes, and it's so functional, inconsistent, triggered, the fit criteria, and we can interrogate that as we talk to the patient and as we're taking the history and just really getting curious. Now, at that point, it feels to me like before a doctor would even start doing this, they would need to believe that this is possible, that functional pain is possible. So, first, the doctor needs to believe in order to dive deeper into this work. And then we need to get buy in from the patient. In the decades of work in this field, what have you found more challenging, to get buy in from the doctors or buy in from the patients?
That's a great question, Alex. Buy-in from physicians has been slow.
Okay.
It's been slow. It's not what people are taught. It goes counterintuitive. It goes against what we know as physicians, or we thought we knew. It means taking more time. It means trying to explain things that are sometimes hard for people to hear or understand. Certainly, there's been many patients who've taken my book or this material and thrown it against the wall and been upset because they hear somehow, if it's a mind-body condition or if it's a neuroplastic condition, they hear it's in my head. And so that's the issue that we really need to address. The thing about wanting to do this work, I think shouldn't be that hard, because doctors, if you really care about your patients and you see their suffering, even though they may not be dying of cancer anymore, but you see how much they're suffering, you want to help them. Of course you do. And patients are suffering. They want relief. Of course they do. And almost all the patients we've seen have tried traditional medical therapies for their chronic headaches, back pain, IBS, chronic fatigue, anxiety, depression, et cetera. They've tried all those. And if they work, great, that's fine. But if they don't and they continue suffering, that's where this work comes into play. So it's when people are basically, they're desperate.
Mm-hmm.
And so if you're desperate, hopefully, if your physician really cares about you and you're desperate as a patient, hopefully they can begin to at least explore and say, well, geez, there's these other ideas that have really helped a lot of people.
Mm-hmm.
Controlled studies, high quality studies showing that the treatments we've developed are effective or can be effective. And it just requires opening our minds to look at the power of the brain to cause real symptoms. And what I always say to my patients is, anybody who says the pain is all in your head is not understanding pain, doesn't understand the science of pain. Sometimes they're being dismissive, judgmental, maybe even cruel,
Mm-hmm.
because what I know and you know, the pain is real. It's not fake. It's not imaginary. It's not all in your head. It's not because you made it up. It's not because you want the pain. It's not your fault. You're not crazy. You're not defective. It's real pain. And real pain can be generated by the brain in the absence of tissue damage.
Yeah.
And that's amazingly common.
Mm-hmm.
When that happens, if it's true for you or for somebody, there's a chance of reversing it. So that's the kind of message that I hope we can give to our patients.
Yeah, I really love what you said there about really connecting with the patient and reassuring them that it's not in their head and it's not their fault. And really communicating that as many times as needed until they really hear it on a visceral level and not just on a cognitive level. And thank you also for referencing me there at the end, because at the end of our course, I actually developed chronic pain. And it lingered on for a while, and you and I worked together on it using this method. But where I arrived ultimately with it was not being able to remember why I needed that pain in the first place,
Mm.
because it served a purpose. But there came a point where I could no longer remember why I needed it,
Mm.
and I didn't have it anymore.
Wow.
So it's just beautiful work, and I have personally felt it, and I know that it works. So I can really just shout it from the rooftops in the clinic and in my personal life.
Yeah. See, because sometimes, as we were alluding to before, the pain starts with an injury, cancer, chemotherapy, etc., but then lingers because of learned neural circuits.
Yeah.
But there's another way that pain often starts, and that is based on the research that shows that a physical injury activates certain regions of the brain that are responsible for pain, and an emotional injury activates the exact same areas of the brain that can be responsible for real pain. So frequently, when people start having headaches, migraine, irritable bowel, chronic back pain, chronic pelvic pain, fibromyalgia, um, small fiber neuropathy, chronic fatigue syndrome, etc., frequently there's stuff that's going on in their life that it's causing their brain to react in danger, because the brain reacts with the danger signal to physical injury, but it also reacts with the same danger signal to emotional injury. A child who's using drugs, an aging parent who's sick or ill, a spouse that's cheating, workplace stress, unfairness or injustice in the world, political polarization, and guess what? Having cancer, certainly one of the major stresses that people are under. And like you say, is there a reason for it? Well, sometimes the brain is there to protect us.
Mm-hmm.
And if you're going to work every day and your colleague is abusing you, or your boss is micromanaging you and making your life miserable, and you start getting back pain, well, what is your brain saying? What's the message? You know,
Messages from the body.
yeah, don't go to work.
Messages from the body.
Something dangerous at work, you should not. And because the brain can't tap you on the shoulder and speak to you and say, you got to get out of there, your boss is.
Mm-hmm.
Well, it creates a symptom as an alarm, like a smoke alarm.
Yeah.
That is mind blowing when you see it, and you never see it if you don't look for it. But if you do look for it, it's amazing how often you find it.
You've just reminded me of another quote that we had in our coursework that says, "Nothing records the effects of a sad life so graphically as the human body." Now, replace the word sad with any other emotion word that you'd like, but still it's recorded in the body. And it also brings up this notion, or actually, perhaps it's my own personal view, so I don't want to generalize it, but it feels to me more than not that this word emotion is very much feared in the context of clinical medicine. It's like, just give me the facts, just give me the scans, just give me the numbers, give me a blood test to look at, give me a chemo to prescribe. Comfortable there, enter emotions into the field, and things start getting a little trickier, perhaps. How can we demystify that working with emotions and really cataloging them and going there with questions and with some tests, like neurocircuitry testing, to understand and profiling that landscape for a patient together isn't as daunting as some people may believe? Can you give us some examples?
Sure, when when people have when doctors have to tell patients bad news, they have to tell them about cancer or recurrence of cancer or metastatic cancer. Obviously, it's a very emotional time. What do we expect? We expect sadness, we expect grief, and sadness and grief um, are emotions that our brain creates to help us cope with situations that are difficult. Sadness and grief call for connection. Why do people cry? So people will give them tissue, so people will hug them, so people will care for them. It's a call to connect. And what happens when people are not in touch with their emotions, not able to cry? They hold everything in and everything's fine. No, there's nothing wrong. I'm not sad. It's like, we'll deal with it. Everything's fine. And oncologists may like those kind of patients because they don't have to deal with the tears. But on the other hand, research shows that holding emotions in actually can cause the danger signal to get activated, which can cause pain, fatigue, anxiety, depression, other symptoms. On the other hand, the emotion the other major emotion that comes up in people with cancer and other stressful things in their lives is anger. And what do we do? Well, we don't like anger. Doctors don't like angry patients, right? It's not pleasant. And is it? But anger is a normal and healthy emotion when someone gets cancer. Why wouldn't you be angry? Who wouldn't be angry about that?
Yeah.
When your boss is micromanaging you, who wouldn't be angry about that? Et cetera. So when there's injustice in the world, who wouldn't be angry about that? And again, research shows that people who hold in their anger and don't express it at all or aren't aware of it are more likely to get these physical neuroplastic type symptoms. And so one of the things that therapists have had to learn, and a lot of therapists are really not that comfortable with sadness and anger either. But anyway, and physicians certainly aren't. But what we've had to learn in this work is to help people identify and express their emotions in safe and healthy ways, which can actually help to unburden the danger signal in the brain. And so we've developed a form of therapy called EAET, Emotional Awareness and Expression Therapy. Mark Lumley developed it, and research on it, good quality randomized controlled studies. It was just mentioned, I was talking to you earlier, it's just mentioned in the up-to-date chapter on chronic non-cancer pain mentions EAET as one of the recommended therapies based on the research we've done. One of our colleagues, Brandon Yarns at UCLA, has done amazing research on this as well. And it turns out that emotions are related to pain. Yeah. And there's simple ways to help people identify them, express them, release them, and move through the emotions to connecting emotions of compassion and caring and forgiveness and acceptance, which all lead to decreases in these neuroplastic pain conditions.
And what are some other types of testing that we can do in the clinic? That three-step notion where we try out movement, light touch, and firmer pressure. What does that look like practically, and why would we even do that? What does it show us as a test?
Yeah, so not everybody does this. I use this a lot. I call it provocative testing or neuroscience.
Uh-huh.
One of the things, there's a couple ways to think of that. One is when you are talking to somebody and you start talking about something that's stressful, talking about something that's scary or dangerous, and all of a sudden you're talking about that and somebody puts their hand to their neck, that's a sign that you've provoked something of an emotional nature that creates pain, or their stomach starts to get tense, or they start to get shaky and anxious. And so you can see that connection to emotions. The other way that we use this provocative testing is to uncover when conditioned responses are occurring. So if somebody has back pain that hurts when they bend forward, they're standing up, they don't have pain, they bend forward, they have pain, that sounds like a structural problem. But maybe the pain shifts and moves and turns on and off and is related to the weather and stress, etc. So you've taken that history. And so one of the little tricks that I've used over many years now is to have someone stand up, close their eyes, and imagine bending over. And they often get the pain, maybe a slighter amount, but they get pain. And it's showing that it's not actually the bending over that's causing pain, it's actually their brain that's fearful of bending over. And that's the neural circuitry that's causing pain. And we can help people by lowering their fear. So in addition to the emotional treatment that we use, we also use pain reprocessing therapy, PRT, which has again been shown in high quality randomized controlled trials to reduce chronic pain and even eliminate it in roughly 2/3 of the people who was treated. Amazing. And so that therapy consists of lowering the fear of the movement, lowering the fear of the pain, lowering the reactions that we have to it, and giving the brain a different message about the pain, because the brain is responding neuroplastically. The brain is always changing, it can always change. And if we start teaching the brain that it's safe to walk, it's safe to sit, it's safe to move, it's safe to eat those foods, it's not dangerous to wear these clothes, the brain will learn that, and that can make a huge difference in pain. So that's another form of therapy that we use.
And to your point, their brain is always changing. So I feel it's really important for everyone to hear that you can do this at 17, you can do this at 57, you can do this at 87. Age
Yeah,
really doesn't matter.
yeah, exactly. Yeah, and some of the most, I remember I was just writing this in my new book. There's a woman, I got an email from a nurse practitioner in
Hmm.
Pennsylvania, and she worked in an OBGYN clinic.
Hmm.
A lot of women with chronic pelvic pain. And she felt for them because it was so distressful and annoying and devastating to have chronic pain and keep going to more and more doctors, get injections, get medication, get tests, even get surgery. No better, not better. Years and years. And she then herself started getting pelvic pain. And it got worse and worse. And it lasted for 3 months. And then she says, oh my God, it's chronic. And then it lasted for 6 months. And now she knows she's not going to get better, right? This is a horrible place to be at.
Yeah.
And she happened to, somebody suggested she get this book, my book, Unlearn Your Pain. She read it. She started doing the exercises. There's some writing. She understood it in a different way. She started giving different messages to her brain. She started dealing with some of the stressful issues in her life. And in 2 to 3 weeks, her pain went away. And then she was like, that's amazing. But what do I do now? Am I going to be able to tell my patients about this that I'm seeing? Am I going to be able to own up and say, hey, I had this, like you just did, Alex, for to her to say to her, hey, I had chronic pelvic pain and I'm better, and here's what I did. And so she's a week or two after that, an 84-year-old lady came into her clinic, and that's why I'm telling this story. And this lady had pelvic pain, chronic pelvic pain for 24 years. And she had been to doctors and doctors and doctors up and down the East Coast, no help. And she said to her patient who she loved, this older lady, she said, you told me you had a flare of your pain toward the end of November, start of December, a few weeks ago, the pain got worse. Was there anything going on in your life that might have triggered that? Anything that was on your mind? And this woman said, she said, I've been doing Christmas my whole adult life. I'm in charge of Christmas. I do the decorations, I do the cooking, the cleaning. It's my thing. I love doing it, and I'm getting older. And I don't know if I can do it anymore. I don't know if I can do it this year. And that's causing a lot of stress and a lot of grief.
Hmm.
And this nurse practitioner said to her, maybe you should read this book. So she got the book. And 1 week later, her pain went
Wow.
away. An 84-year-old lady. So, you know, if the diagnosis is correct, it gets back to making an accurate diagnosis. If there's an accurate diagnosis that somebody can understand, that the doctor can understand it, that the patient can understand it, that it makes sense. They've tried everything else, nothing has worked. Why not open your mind to try a mind-body approach? It's been effective for lots of other folks. I've got a list. For my new book, I'm collecting lists of people who've benefited from this. And we've got over 750 names so far on the list worldwide, people all over the world.
Yeah.
And so, what have you got to lose, really?
I was going to say exactly that. Why wouldn't we try it not as the last resort, but concomitantly as the first thing we think about?
Well, most of the physicians and therapists who do this kind of mind body work are people who've had it themselves. Because it's hard to even imagine that this could actually be the case unless you've had a personal experience with it. And so people like us, when we get a new pain, we're going to like, oh, it's probably my brain. That's the first thing.
It really is.
I mean, that could be wrong also, obviously. It's like, oh, my shoulder's hurting. Well, oh, it's probably my brain. And then I call my brother, who's an orthopedic surgeon, and he goes like, Howard, you've got arthritis in your shoulder. What are you talking about?
Well, when we combine both, it's really magical. It really, really is because it's a holistic view. We see the whole person and not just a joint or not just an organ. It's such a whole experience for both the patient and the physician.
Yeah. And there's some data. There's no randomized controlled trials of the mental health aspects of physical illness. There's not a lot of randomized controlled trials. Like, do people who are happier and more fulfilled, do they have better outcomes in after a heart attack? Or do people with cancer have better outcomes if they have better, closer relationships in their lives and meaning and purpose? We don't really know that. But there is some data that suggests that people who rate their health highly, people who have meaning and purpose in their life, people who have good social connections live longer. There's that kind of epidemiologic data. And why ignore that? Why not think about, as you're suggesting, the mind and the body together, and why limit our treatments to purely physical treatments?
Yeah,
The uh, if the mental health treatments or emotional stuff is not that hard to do or explain. Um, you know, maybe,
absolutely. I mean, thankfully, I feel like in oncology, we're starting to listen and really hear this message, and it's starting to land. Some books that have been around for a number of years are making their way into people's hands more and more, specifically around oncology, such as Radical Remission by Kelly Turner, Cured by Jeff Radiger, and they speak about these aspects specifically that you've mentioned. People who have more meaningful connections, purpose, and are simply fulfilled and content. There's perhaps not in a randomized clinical trial concept. Hopefully, we'll get there, but the connections are definitely there. Now, the piece that is, I feel important also to mention, because we start with it, and I feel like we need to carry that piece throughout the journey with our patients, whether we're working together with them or we're advising them and they're embarking on it and they're going to do it alone. And for example, grab one of your books and do it themselves. But the education piece is really important. Why is the education piece so important? What does the education do to our brains?
yeah. There are certainly a small but significant number of people who we've seen over the many years, who have read a book about these concepts. Dr. Sarno, John Sarno's person who started me on this track back in 2003. He'd been doing it for 30 years before that, as a physiatrist in New York City. And his books are still selling quite well. And there's been thousands, literally thousands of people who've read one of his books and their pain went away on the spot because they had a different way of understanding it, a different way of giving these messages back to their brain that, oh my God, I'm not really damaged. It's actually my brain, not my back, not my stomach, not my head. I can get better. All these other people got better. And, we're not talking about 50% or 80%. We're talking about 10, 15% maybe. But for those people, the education alone is really enough to make their symptoms go away. And for the other people, the education is the starting point. It's a starting point to help them begin to understand that the brain can and often does cause real physical symptoms, and that there's a chance for remission.
Now, I wanted to again remind people as we're wrapping up about what these components of the neural circuit retraining therapy are. And then please, afterwards, if I've missed something out, you will correct me. So we're confirming the diagnosis. We're ruling in or out structural and ruling in or out the functional. And you've taught us how to do that. We're educating the patient about neural circuit disorders and getting their buy-in. We're taking a very thorough history, and that includes lifetime stressors, current stressors. We're talking to them about their personality, their physical, emotional symptoms, and we're going through that fit criteria, functional, inconsistent, triggered. We're getting that whole history in place. And hopefully during this process, we'll get the buy-in from the patient that this could be a mind-body thing, functional process. And we're teaching the patient PRT, so pain-specific cognitive and behavioral techniques, and then using emotional processing therapy, EAET. And really that entire journey, which as we've heard can take a few days or it can take a little longer or a few months, it's really very personal and individual, gets our brain out of fear and therefore out of pain or reduces it significantly and back into our optimal health.
Yeah, perfect. That's beautiful, Alex. It can take 3 months, 6 months, can take a year. I've seen people take 2 years, which is frustrating when they read about people who took 2 weeks. It's frustrating to hear that, but it is different. Some people need more of the emotional processing work. Some people need less of that. Sometimes people need to make a change in their life. Sometimes they need to change their job. Sometimes they need to change a partner or romantic partner. Sometimes they need to set boundaries with people in their lives, sometimes even family members. And oftentimes people need to change how they treat themselves. And you mentioned one thing a little bit ago, what we would call personality traits, because people who've had difficulties in their life, particularly those with childhood trauma, often have learned to be unkind to themselves, to not feel they deserve to be happy, to feel like they're critical of themselves all the time, they're harsh with themselves, they put themselves last, they people please, they put everybody else first. And so they're kind of inauthentic to themselves. They're not really living up to their true self. And that is an area that can make a big difference in people's lives. And as I think you pointed out earlier, can be an advantage, a benefit, in a sense, a gift of the symptoms coming to us to teach us something. Our brain is trying to protect us, is trying to help us. And maybe part of the message for some people is you need to stand up for yourself. You need to take care of yourself. You need to take time for yourself. You need to speak your truth and be authentic in your communication with your kids or your parents or your spouse or whoever. And that can be a beautiful thing and a growth experience that people can have.
I think it's a beautiful place to really leave everyone with. As you just said, it can also be perceived as the gift of pain and learning so much more about oneself, and the way forward gets to look different and gets to feel different.
Right. Yeah. We don't start with that. People would strangle you if you tell them, "Oh,
I agree.
never lead with that." But maybe at the end, sometimes people can actually see that and they towards compassion, because really a lot of this work is about compassion. It's about the patients, caring for them, loving them, wanting to help them in whatever they need. And if this is what they need, then maybe our caring physicians are willing to explore that and learn about it for themselves. and help to educate people about it. And some patients will buy into it, some won't. Some may think about it, and a year later they may be interested.
Mhm.
But if it's done, if this explanation is done with compassion and caring, then usually it'll go pretty well.
Yeah, and it's beautifully enriching for a practice. I'll speak for my own practice. This has been really a game changer, and it's a beautiful two-way street. It benefits certainly the patient, but also in this case, it can benefit the oncologist too.
It's been so satisfying.
Yeah.
And I mean, as an internist, oncologists save people's lives. I mean, that's what they do. And internists don't do that very often. So, in my career as an internist, how many lives have I really saved? Not that many, but this work, people will come back and say, you saved my life every week. I get emails from people I've never met telling me you saved my life and I didn't do anything. They deserve all the credit, of course, but these ideas can be life-saving.
Yeah, they really, really can. So we are going to make sure that your books, the links to your books are available for everyone who's listening or watching this conversation. And can you tell us a little bit about the resources as well? Where can people find you? I know that you have a lot that you offer to people for free as well. Where can they find this work?
Well, we have a nonprofit, the ATNS, Association for the Treatment of Neuroplastic Symptoms. That's at symptomatic.me. All free resources. There's a huge bibliography. We have an annual conference people can come to. It's coming up in Boulder in September. We have a ton of stories there. There's CME courses online there.
Mhm.
I have a free course on Coursera, the Coursera platform, coursera.org/learn/reign of pain, REIGN hyphen of pain. At my website, unlearnyourpain.com, there's a bunch of courses. There's a whole list of continuing education courses that we teach in pain reprocessing and in emotional awareness and expression therapy. So those are two resources. There's also something called the tmswiki.org, which is a peer-run, patient-centered, free website for tremendous resources and practitioner directories.
Excellent. We will make sure to list all of that in the notes. And I really do encourage everyone to get curious and dive in. You will not be disappointed. I can promise you that. It is going to change your life. Howard, thank you so much for your time. Thank you for your wisdom. Thank you for the new book that is yet to come. And I really look forward to just continued collaboration and following and learning more from you.
Thank you so much. Thanks for having me. It's been a pleasure to know you. You're a great person. Thank you.
Thank you.